vaccinated, but extenuating circumstances plus general vaccine fatigue really kind of cut into that. So that's my personal anecdote. Anyway, now that we're back online, so the first 8 minutes or so, we're going to be talking about typical community viral circulation and then the impact of the pandemic and then what to expect. So as many people here know, particularly if you're a pediatrician, usually for RSV, right, respiratory syncytial virus, you could set your clock to that, more or less. You'd have upticks in November, peaks around Christmas, and fading by January, February. And to the degree to which peds hospitals would set their like bed capacity and nursing staffing based upon RSV surges. That has not exactly been the case, as we'll discuss. For flu season, the first week of flu surveillance by the CDC is typically week 40, which is this week. So typically, in the later bits of October, you would start to see flu upticks. And flu is kind of like a slower burn and a longer lag. So you'd have people, maybe a first peak, in December or so, and then you might have a second peak sometimes later in February. That can be for a couple of different reasons. Waning of flu vaccine immunity, flu B, which tends to come a little bit later, and some aspects of seasonality. And then all the other viruses, they don't necessarily all follow seasonal patterns, and if they do, it's not usually necessarily winter. Rhinovirus, common cold, is basically undefeated. It was one of the only things that were getting people sick during the pandemic, despite shutdowns. So that's like background. You go to the next slide. So what we all know is with shutdown, right, other viral infections are basically crushed in a good way. Then we reopened, and we've had viral infections, but in atypical patterns. The classic being, as we'll talk about in a second, this unseasonably early RSV wave that happened last time around. So the forecast is still a little bit cloudy. I'll give my mildly educated opinions, and I think we are going to be a little bit closer to the norm this season, but may not be totally following the pattern that I described in the first slide. So let's go to the next slide. This is from the CDC, and this is typical RSV curves. So you can see 3 almost totally overlapping blue lines in the middle with a peak around New Year's. That's what's normal, right? But then in 2022-23, the dark black line, you see how it was shifted earlier. We had that unseasonable wave. And then right now, as we'll talk about in a second, it's not quite certain where we are on these curves because we don't have a ton necessarily of RSV. So that's a typical for RSV. And you can find, we're in week 40, as I mentioned, right, the first week of October. Next slide. This is what I just described with flu. Typically, if you focus on, let's say, the purplish line and the teal line, things will start kind of coming up in the later weeks in the year, like we're talking about November and December, and then you kind of have this longer wave, and then it'll come down in the early spring. Right now, our activity, because remember I said that we're week 40, we're the tiny little half dot that you can see above the pink line on the leftmost y-axis. So still below this so-called like epidemic threshold, where you start to say it's at the beginning of flu season. So still the season's not written yet, but there's not a lot of flu. Okay, next slide. And then this is just an example, as I mentioned, about how the pandemic really screwed everything up, but sometimes in a good way. There were no flu deaths, basically, in 2020-21 because we weren't around each other, right? And then we had a little bit of unseasonably early and pretty intense flu season in last year. Still not written for this year. All right, next slide. Now, COVID has been different, right? It hasn't followed a seasonal pattern per se, though there tend to be, and if you look at this slide, the axis is a little bit shifted, but that tall light blue peak there is the Omicron wave, and that's kind of actually like around the holidays. There is usually a seasonal bit, and coronaviruses in general tend to follow a December, January peak, pre-COVID coronaviruses. So where we are now is that series of dots that have been highlighted. This is using actually wastewater monitoring because case counts are no longer reliable in the United States because most people are doing home testing. And you can see we had this bit of a bump actually, and if you go to the next slide is an animation, I think. Wastewater upticks were starting in late July and kind of crested just a few weeks ago, where we had this sort of mini wave that's kind of plateauing now. But there's still, of all the respiratory viruses circulating, it is still probably on balance the most common as compared to the other respiratory viruses I just mentioned. But what I would expect, and I think you can go to the next slide, if we're forecasting, is that we're probably going to have another December, January wave of some kind, but the magnitude is not totally clear. It's not going to be as high as any of those, like the sort of the bad times, first wave or Omicron wave. There'll be some degree of wave owing to seasonality, mixing, holidays, and the fact that we've been hitting this kind of like 3-month periodicity in terms of these mini waves in the Omicron era. The variants are shifting, and I wrote a couple of them down there. And that does add a bit of a wild card, but I would anticipate that that will happen. Rough forecasting. And then the last two things I'll just say briefly, and again, sort of in the interest of time, is we're probably going to start seeing flu uptick more in November, would be my guess. And I think we're probably going to have a somewhat normalish flu season, but it's just a guess. The RSV has come to some parts of the United States, and weirdly, paradoxically, the viruses tend to kind of come up from the southeast and in Texas because of from the southern hemisphere into the northern hemisphere. And we already did see some upticks in the last month in Georgia, Florida, places like that. And I think that'll actually probably continue. So I would bet in the next few weeks we start seeing more RSV, but again, assuming can be difficult in the pandemic times. All right, so that's just a summary of like epidemiology, when we think things are going to come, when they typically come, etc. All right, so let's actually talk about different viruses. Next slide, please. This is a little bit of a sidebar that you may or may not be familiar with, but there is this idea when we talk about viral periodicity that the viruses kind of compete with each other in ways that are complicated. But I think that plot down at the bottom is something worth noting, which is rhinovirus and flu A almost have these totally opposite seasonal patterns. And reasons for that are still totally not certain. This has come up a lot in the COVID times where people are wondering if you have COVID, are you going to get another viral infection or not? Is it going to be worse or better? And there is some evidence probably that things like rhinovirus may damp down the short-term risk of other infections, including COVID, which is interesting for reasons that I kind of listed in that kind of hand-wavy subpoint in bullet 1. But what is less well understood and what has been in the public eye, I think, is whether because people are getting COVID, recently had it, for example, whether your subsequent viral infections will be worse. I think that's a question people have. And I would say some of that is a little bit obvious, that if you do get a viral infection, you get another one after, you're probably going to do worse than if you didn't have that first viral infection. So it's a little bit academic. There may be other kind of deleterious mechanisms that still are kind of getting sussed out. I would really caution against this somewhat viral, no pun intended, idea about immunity theft, or like COVID causing people to have worse immune systems. Basically no evidence for that. The concept of immunity debt, which is a little bit also mushy, but I think is a little more legitimate, because as you could see from all those slides of viral circulation in the COVID times or not, there was a lag about people being exposed. So we do boost our immunity against things like RSV or whatever every year because so many of us get it. And we missed it. We missed a season. So more people are technically vulnerable. And so you're going to get more people who are going to get infected. And some of those people may do poorly. So I think there's a little more legitimacy to that. That also holds for children, because pregnant people were not getting infected. So passive immunity to the child was also reduced. So you might have seen kids who get worse RSV or something like that because their moms weren't getting RSV. So I actually believe in that. But there's really very, very little evidence that, unless you had just had an infection that you didn't get over, or you have severe lung disease or something, and you had COVID, then you could get worse from COVID. But it itself and history of that doesn't really seem to be the thing that's driving other respiratory infections being worse. So just wanted to throw that out there in case people ask you. All right, next, please. All right, so let's talk about risk. So I made this graphic for a work I've done with a couple of partner organizations, and I may have presented a version of it before. Or people are coming to you, let's say they have COVID or they're worried about COVID, and you just want to like give them a sort of a snapshot about the personal risk. This does more or less hold for other viral infections, but COVID's been in the news. And I tend to just sort of think about where would a patient be and kind of circle them on the across these different spectra of risk, from lowest on the left, the highest on the right. And long story short, for COVID or other viral infections, the greatest risk is age. People who are elderly, 70, 75, 80, are going to be at highest risk, kind of irrespective of their other demography. So that's a pretty easy proxy for counseling. But not every age is a number to some degree, and not every 80-year-old is the same. And so accumulating comorbidities, diabetes, obesity, hypertension, heart failure, etc., will shift people. Kind of their biological age can be shifted in one direction, or the other. And then lastly, vaccination status, or what I'll probably term exposure status, because it has been recognized that infections do protect you against subsequent infections. If people have had a booster vaccine or an infection in the last 2 to 3 months, the risk of getting infected again is quite a bit lower, and the risk of having a severe infection is also quite a bit lower. Again, assuming you haven't had some serious complication of your first infection that led you to have horrible lungs or something like that. So, but as you move towards the right, people are on or under vaccinated. Those are going to be high risk people. And then lastly, immunosuppression, which has been in the news. It's actually a pretty wide spectrum. You can see all the different medicines that are here. And we've got quite a lot of people who are on prednisone or TNF alpha inhibitors, or they take some medicine for some other autoimmune disease. And these are kind of a rough map out about how you could eyeball what somebody's immune substrate is. And this matters because if you had a bone marrow transplant, you're not good at fighting off viruses if it was done recently. And also, that status interferes with your vaccine-associated protection, right? So sort of like a double hit. So if you think about yourself, or you're thinking about people in your panel or whom you follow, this kind of framework I would suggest is one that you could, present. And I would say, among all of these things, kind of the only modifiable thing is getting vaccinated or boosted. So that can be a bottom line. If you haven't had a vaccine or a booster in the last few months, your risk of infection is going to be a lot higher. And then your risk of severe disease is somewhat associated with that, but also the rest of where you might map out in this kind of, spectrum. All right, next slide, please. So let's say we've established our risk profile. We're now experts in that. The guidelines are to treat if someone is higher risk. Lots of red on the spectrum I just showed, right? So you're old, no offense, elderly, multiple medical issues, no recent infection or booster, which I tend to think about in the last, particularly 3 months, somewhere in the 3 to 6 month range. The basic algorithm is Paxlovid is a recommended first-line drug if people can take it. If you can't take it and you're really high risk, technically remdesivir is recommended, the intravenous antiviral. But it's not that easy to logistically operationalize unless you're at like an academic medical center and it's your patients, etc. So molnupiravir is listed as a third-line drug. It can be given. It's much cleaner in some ways, but dirtier in others, so to speak. And for each person, you're kind of going to need to fit the drug to their profile, which we'll talk about in a second. There are some major constraints that we'll discuss. Some are listed here. Next slide, please. So the biggest one that you may run into in your practice is Paxlovid interactions, right? I mean, how many patients who are elderly on medications are going to have a clean slate when you put them into some interaction checker? Not that many, right? So there are some amazing resources out here. Like I took a snapshot from the Liverpool drug interactions thing. You could just Google. NIH has some cheat sheets, which are on the right, a bunch of other guidelines. And if you're not sure about it, I would always just recommend talking to a pharmacist who are going to know things better than physicians in many cases. But I had the other day had a person with lymphoma who surprisingly was able to take Paxlovid, and I did prescribe it because I was like, great, you're the person for whom this would be likely to reduce your risk. And remember, we started our discussion with establishing that someone is higher risk, which is, again, really driven by age, but also the other things. The data for Paxlovid to prevent hard outcomes in younger people and people without comorbidities is not very good. The jury's a little bit out in terms of limiting duration of symptoms or reducing things like long COVID, for example. There aren't a ton of data to support that as well in younger, healthier people, but theoretically, it might. And so that's a little bit of the, if you technically meet criteria, and the criteria are pretty broad, to be honest, for whom would be eligible, and you don't have contraindications, that's a discussion point, case by case. I know young, healthy people have taken Paxlovid because of those two specters I just mentioned. Like, I got to go back to work. I don't want to get long COVID. You know, I never had COVID before. I don't take any medicines that would be contraindication, and they took it, and that's up to them. But we're still in the realm of not really strong data to support its use. You just want to do no harm, right? Okay, next slide, please. This is a table I made that just shows in rows the side-by-side of the antivirals in case you need like a quick reference. This is pulled from a paper I wrote that's in Clinical Infectious Diseases. If you just Google my last name and COVID, or my outpatient has COVID, I think it was called. What are my options? And we don't have to belabor this. I feel like the biggest things are, if you focus line by line, remdesivir, it's just hard to give people. I feel like for many people in this call, it's just not going to be relevant, but I use it all the time, you know, in the hospital for people who are very high risk in the community because I have access to an infusion set. The second would be Paxlovid. We just talked about the major issue, which is drug-drug interactions. There are some limitations based upon people's kidney function and liver function that should be recognized. They affect dosing, as well as whether or not it be even authorized. And I don't know how many people have had patients who take this, but there's a decent amount of adverse, reported events like GI side effects, change in taste, does not taste very good, kind of metallic. And then this concept about rebound, which is actually common to all antiviral drugs. It just gets the most rep for Paxlovid. It also occurs in people who have not been treated with antivirals. There is a second phase sometimes for people, around day 7 to 10. So I would bet, to be honest, if we had trials that were designed this way, that a 7-day course would probably blunt off some of those rebound things, but that's not how it's currently prescribed. So you do see, depending on the study, 10 or plus % of people that they might have a rebound of symptoms after cessation of Paxlovid, but it really varies. And generally speaking, what you can assure people is basically no one who's had a rebound syndrome has been sick enough that they have to go to the hospital in any study. Some people have been able to have a positive antigen test again after being negative. So the potential to onward transmit or be contagious again is a real thing, actually. And that's why, President Biden got a second round, and Dr. Fauci, et cetera. I mean, you don't feel so good and you have a positive test again, it makes sense to treat again. And that's what we have done. And the last one I want to talk about is molnupiravir. Has the weakest clinical evidence, very good in vitro evidence, kind of mixed evidence in the real world. But for people who are high risk, who you can't give the other medicines, it's very reasonable. It probably works, but it is more in the sort of Tamiflu side of things as opposed to some probably very potent antiviral. The biggest things are these concerns about mutagenicity or teratogenicity, which are mostly based on mouse studies, but are a reason why we don't give it to children or pregnant persons, and I wouldn't do that for basically anyone here. But that would be my recommendation. There are rare cases where it's done, but pretty much not recommended. There was a question, I think, flashing up in the chat. There's so many questions about metformin. Of all the things I've listed down here, it is the only one that in a randomized trial has some evidence in reducing some COVID outcomes, including potentially long COVID to some degree. Hasn't been redemonstrated in another population. Really just one big trial group did that. A very legitimate trial group. Mechanisms are also a little bit fuzzy. That said, it's cheap, it's well tolerated. If someone asked about it, you could direct them to I think it's can't remember, it's in the Lancet, Bramante, Bramante is the article you could reference. That group was not, there were not people who had boosters, for example. There's some people who were unvaccinated. It was a little bit earlier in the pandemic, so generalizability to today is a little bit less certain. But could be part of a shared decision-making discussion, but it's not in any guidelines. So put it that way. Next slide, please. All right, so that was COVID. Maybe I unfortunately have like a lot of all right. We'll keep going. We'll try to do questions at the end unless there's something really burning that you want to talk about before we circle back. So now we'll talk about RSV because I feel like it's the other really important development that's worth reviewing in depth. So what's been, I think, under-recognized is that RSV and influenza cause about the same morbidity in the elderly. But we think of it as a disease of children because it's much more common. It's the #1 cause of basically hospitalization in certain age bands of younger children. But almost 10,000 people could die a year from RSV, and they're mostly elderly. There was just a recent MMWR from the CDC that showed that among hospitalized older adults, and they specifically chose 60 because that's where the RSV vaccines are authorized, about 5% of those hospitalized people died. And they were mostly the elderly, people over 75 or 80. Almost everybody had some condition. Many were in long-term care facilities. So the vulnerable, kind of using again the same kind of paradigm that I showed in that COVID continuum graph, does more or less still apply for RSV like it would for influenza. And it was shown in this study and in others, if you have RSV and you have COVID at the same time or influenza, those people tend to have worse outcomes. Probably a little bit clouded by like who gets both of those at the same time. Your immune system's probably not so hot, or your luck is bad. All right, so that's the background of RSV. Next slide, please. So, but we have a revolution. A little bit of a bittersweet revolution because if we didn't have any of this COVID stuff, and this were coming out, this would be like people talking Nobel Prize, pediatricians dancing in the street, because it has the potential to be enormous impact. But because of COVID, vaccine hesitance, vaccine fatigue, it maybe isn't as portrayed as dramatically as I kind of wish it were. But there are 2 approved vaccines for adults to prevent RSV, and they both work really well in the trial setting. In trials of more than 10,000 people, who are mostly older adults with some medical conditions, the effectiveness over the course of 1 or 2 RSV seasons to prevent RSV, both particularly lower tract infection or medically attended events, was very good, approaching 80%. You can see the curves here. These are on the left and right, the GSK and Pfizer vaccines that we'll talk about in just a second. So pretty amazing, considering we literally did not have this until recently. The brief backstory you might remember on RSV vaccines. The original version actually caused probably something similar to antibody-dependent enhancement. It was given to children, and more children died who received the vaccine due to immunological crosstalk, and that set back the field quite a long time. But that was a long time ago. We got different technology, very, very, very thoroughly vetted. All right, next slide, please. Sorry. So these are the side-by-side of the vaccines that I think maybe just worth kind of taking a look at. The GSK vaccine on the left and the Pfizer vaccine on the right. I'll start on the left. I'll kind of go side-by-side. How about that? The GSK vaccine, called RSV, is adjuvanted. It has the same adjuvant as the Shingrix vaccine, which some people might have received, but at about 1/10 of the dose. The Pfizer vaccine is protein-based, not mRNA, but not adjuvanted. Adjuvanting being like an immune booster that's a part of the component of the vaccine that is supposed to recruit immune cells and improve immunogenicity. The GSK vaccine is monovalent, technically, RSV-A, which is most of the RSV we see. The Pfizer vaccine is RSV-A and B, for what that's worth. The GSK vaccine, because it has an adjuvant, causes more side effects. Sore arms, chills, etc. Pfizer less so, but it's coupled with probably better immunogenicity, higher levels of neutralizing antibody. And it turns out that the RSV-A vaccine, when it's adjuvanted, has a lot of basically very similar activity against RSV-B due to the similarities in the pre-fusion F protein. That's the one they put in the vaccine. Another quirky thing is that in anticipation of when these things will be given, they were co-administered with flu, typically either a high dose or an adjuvanted flu vaccine. And there wasn't an effect of the GSK vaccine, but actually a moderately lowering of flu titers in people who received the Pfizer vaccine and an adjuvanted flu shot. We have no idea if this has any clinical significance, but it's pretty consistent. And then I'll just say the last thing that we'll talk about on the next slide that's relevant is the Pfizer vaccine is authorized for pregnant people, and that's not the case for GSK. What's quirky one more thing. What's quirky and interesting is that both shots appear to provide protection beyond one RSV season, and they're only kind of marketed as a one shot. So I can't forecast exactly, but we'll have to see in the real world about the periodicity of this vaccine. Is it going to be more like pneumonia shots that you get every 5 years, or is it going to be more like flu shots? We don't really know. I would bet it's probably every couple years, but TBD. Okay, next slide, please. Now, the other thing that's fantastic is that there's a kind of a dual availability of protection of the most vulnerable to RSV, which would be little babies. And we have both passive and active immunoprophylaxis. And these are on the right, you can see two of the curves here that are very similar to the ones you just saw. Honestly, if you have a good vaccine or a monoclonal antibody product and you give it at the right time, they tend to be 70 to 80% protective against the severe outcome. It's pretty amazing that it's kind of similar that way. And that was the case here. So the Pfizer vaccine is recommended for women, but a pretty narrow slice of pregnant people. Pretty narrow slice here, just between 32 to 36 weeks for people who are going to be heading into an RSV season. That's pretty hard to thread that needle. Part of the reason is people are just a little bit gun shy on pregnant vaccines. There was a very slight signal for prematurity and some other measures in the trials in the people who received active vaccine that require further study. And that's why they sort of timed it for this time where they think that maternal transfer of antibody will be high and the risks of prematurity are low because you're already like approaching a reasonable term. But this is complemented by nirsevimab, which is this monoclonal, which I think relatively amazingly and probably not clear is technically recommended for every child that's born entering or approaching RSV season. Like, can you imagine the difference between what that recommendation is and probably what's happening? It's pretty crazy. And then for kids who are entering their next RSV season who are at higher risk, that IM injection is also recommended. The problem is it costs like $500, and insurance coverage is really not well sussed out. Supply is not really sussed out. I have no idea if any of you have ever given this or recommended it or heard of anybody having it. Now would be the time to potentially be giving it to babies, but I've not actually heard of this happening. So anyway, these are ways though to cut down massively on, little kids getting sick, the burden on the healthcare system, the cost of that, and also honestly preventing secondary infections, which are a major issue with RSV in the babies and in older adults. There seems to be actually a big relationship between RSV and things like pneumococcal pneumonia, otitis media, those complications, and that's kind of probably a fringe benefit that in modeling studies is often sometimes built into preventative benefits. Okay, next slide, please. All right, for flu, I feel like there's not that much of development, so we'll try to do it fast. Everyone should get a flu shot in advance of the flu season. The only wrinkle here is, of course, the flu season is a little bit TBD. So I tend usually to say people should kind of wait towards closer to Halloween to get their flu shot because the duration of effect is not the full length of the flu season. If you get it September 1, by the time you're in January, February, that boost is kind of worn down, but I'd get it now-ish probably if people were planning on it. Next slide, please. So what I'll just focus on is just some specific recommendations. I think people know, but probably worth just reiterating. If in elderly people of older age, high dose or adjuvanted vaccines are recommended. So there's a whole suite. There's like 7 or 8 different flu vaccines. And that file down at the bottom is this like quick sheet, which is five pages long from the CDC, but you can look at it. And so these are some of the ones that are in the United States that would be recommended for older people. Something that probably comes up in pediatrics all the time and just worth noting, if you have an egg allergy, that's not a contraindication to any flu vaccine, including egg-based vaccines. This is different than if you've had an anaphylactic reaction to flu vaccine. That's different. If that's the case, then you shouldn't get that one again. But if you just have had anaphylaxis to egg even, it doesn't actually mean you can't even get an egg-based flu vaccine in case that comes up. Any vaccine is better than none, of course, too. And then don't give intranasal live attenuated flu vaccines to immunocompromised people, please. All right, next slide, please. Then treatment notes. This is a little busy, but worth thinking about. So Tamiflu, it does work. You know, if you give it early to high-risk people, like again, those people in the red on the slide I showed, it reduces severe, outcomes related to flu if you give it early in particular. But it turns out you can actually give it to hospitalized people who are very high risk, and it seems to also have a benefit even outside of that window. The thing that people may have done here, and I've done before too, is you can also give it empirically. If you don't have access to a flu shot, people have influenza-like illnesses. In the past, we were pretty good at saying that was probably influenza. Now it's a little bit tricky with COVID, but you can do that. It's actually recommended. But if you give it later than a few days in, and particularly if someone's not high risk, that we really don't have a lot of evidence that it helps. And frankly, my wife's a pediatrician, and even with kids, like the GI side effects she sees are not insignificant. Sometimes hard to disentangle from someone having flu. That she rarely, for example, gives it to kids who are not otherwise really high risk unless it's quite early. Something that just sort of like pinged for me in a way that I hadn't thought about before was post-exposure prophylaxis, which we have done for high-risk people, pregnant people, immunocompromised, tiniest babies. It does work really well. The number needed to treat is like 10. So that's really good. That's better than like almost anything we do. But I don't know how many people do that. It is a very reasonable thing. And what's cool is that we also have baloxavir, which Mike Eisen might have talked about at some point when he spoke with you, who's a colleague of mine, who was the first author in the baloxavir paper. And that's just a single dose, which makes it way more attractive than daily, many days of Tamiflu, which itself have GI side effects. So a single dose of baloxavir post-exposure prophylaxis, but given early, works just as well. It's extremely well tolerated. So I'm not sure how many people have access to baloxavir. I've honestly never prescribed it, but I was trying to think about this, like, your wife has has flu. She's sick for a couple days. She gets a flu test somewhere. It's positive. I feel fine. Would I take a dose of baloxavir? Honestly, probably. I never thought of it. I'm not a high-risk person, but flu is not comfortable. And I got to go to work, so something to think about. All right, so then brief COVID notes before I think we'll end up going into, hopefully, questions. Similar to the influenza and on purpose, the recommendation here is that anyone who hasn't had a vaccine in the last 2 months is recommended to get a single updated, so the monovalent XBB vaccine, either mRNA-based or protein-based, which is the Novavax platform. So Moderna, Pfizer, and Novavax is recommended to get. So everyone's recommended to get that, ages, I believe, 6 months and up. The rationale is, in studies mostly presented by the companies, the improvement in neutralizing antibodies against XBB sublineages, these Omicron children that are running around, is much improved. Sorry, the drug given as a booster dramatically increases neutralizing antibody against that, and it appears at least moderately better than the prior vaccines. But that last caveat is a little uncertain. CDC, kind of buried in their website, does say you can consider lagging a vaccine if you've been infected in the last 2 or 3 months, and it makes sense. Again, as I said, like an exposure is an exposure, and though you're not high risk for another infection or complicated infection in that period after an exposure, whether it's booster or infection. So it is reasonable in my opinion. Unfortunately, uptake of this has been quite poor. Even in high-risk people. I just gave you my own, excuse. So, still recommended. I'm not an expert, honestly, in insurance coverage, but this might come up, so I put a couple slides here, which you can, we can send this out if you'd like after this. But the COVID-19 vaccines are pretty well covered. Medicare, private insurers should be at no cost, to be honest. Medicaid, there's some nuances in terms of state by state. For the underinsured, also the Bridge Access Program, if you look at vaccines.gov, you can actually click a box that says Bridge Access Program. You should be able to get a COVID vaccine for free. We're still pretty good for that, though it's temporary. RSV, unfortunately, is more complicated. It is covered by Medicare Part D if you're in network, and if you ever run into an issue, you can write a script. It should go through. Medicaid may be state by state, and uninsured may or may not be able to get it, and the cost out of pocket's like $300. So this is a disincentive for certain people. Health departments, I know, have been given certain allocations, other places certain allocations, but that one's going to be a little bit harder to navigate. Flu, however, should be super easy and free for everyone. The next slide is one that you can just Google, look online in case somebody asks. It's just COVID-19 coverage. This is from the Kaiser Family Foundation. I thought it was pretty straightforward and better than probably what I just presented. So you can always just Google KFF, COVID vaccine insurance. You'll find this. All right, I think that was my last slide. Great. So that was a lot of ground. I really, sorry about the technical stuff. We have time now, hopefully, to talk about what people put in the chat. And maybe if, where are we at here? Dr. Manzana could, if you want to
absolutely
read them out, that's great.
Yeah, absolutely. Well, first of all, Dr. Werble, thank you so much for that amazing lecture on respiratory viruses. As we head into cold, flu, COVID, and RSV season, it's going to be very helpful for us to know a lot of this stuff. The first question I have on here is from Dr. Holte. Are we expecting a price hike in Paxlovid? And it looks like she sent a link to an article, I think that might just came out today, about how how Pfizer's hiking up the price of or Paxlovid from $500 to $1,400.
Yeah, I read that also, and it seems like that's the plan. There's going to be a lot of public pushback, and I don't know how things are going to be brokered with insurers. And I mean, Medicare here holds obviously a lot of power in terms of like price setting. So but it's possible, and then even more reason to really start with your first principles about risk when you're thinking about prescribing these things, right? Bang for buck. You're 80 versus you're 47 with, out major problems. And I think this, part of it, so there've been a lot on many fronts, clinical and research fronts. COVID funding has been changed or contracts have expired, and that's probably one symptom of that. So I've heard the same thing, but I haven't, I haven't seen it in action yet.
All right. And then we've got a question from Bonnie Berger-Donba. The newest subvariants of COVID sometimes present very much like influenza, i.e. abrupt onset, high fever, etc. If a patient has a negative at-home COVID test, which isn't always accurate, once we're in flu season, can we just consider giving Tamiflu empirically?
I think you can, but I would, through the lens of what circulation is. Right now, there's like very little flu, so that would be probably unlikely. But fast forward in 2 months, it might be very possible. And it is, honestly, most guidelines will say you should treat if you suspect for a high-risk person before the test, which we did in clinic all the time, pre-COVID. So it's reasonable to do. Shared, just like anything, your shared decision-making, ideally someone can get a test at some point to let you know one way or another.
Perfect. Dr. Bardwaj, please discuss any ongoing updates and or guidelines on rebound COVID with Paxlovid. I've had 2 recent patients with it.
Yeah, I think I touched on it a little bit as we went through. It's not insignificant. Again, studies is between like a couple percent, which the company says, and like 20% in observational data. I actually think it's a symptom, no pun intended, of the drug being really good and the virus being kind of sneaky. It really shuts down replication. It's very excellent at that, the drug. But the virus has a lot of immune-evasive properties, particularly like evading interferon and stuff like that we really use to fight off viruses. So you can imagine maybe if things are quiescent, virus is not totally gone, suppressed, antiviral comes off, washes out, and it usually takes like a day or 2 after stopping the drug to wash out. That's why we see rebound potentially. That's why I actually think a little bit longer would probably be better, but that's not how it's prescribed right now. But again, you can counsel people they're not likely to get like truly sick like the first time they have COVID. They may feel not so good, but it's a different situation. Your immune system, it roars back because it was already really recently very primed and attacking the infection.
Perfect. And just as a follow-up question, I think someone, not in this chat, but in our thread, we have our physician thread, had asked whether or not repeating Paxlovid is sometimes indicated. Is that common?
Yeah, I mean, it is done. Again, the higher risk person, the Joe Bidens of the world, you're 80, Andrew Fauci, you're 80. You pop another test positive, you don't feel good, it would make sense to treat again. I think there's, to my knowledge, I haven't seen studies that say the outcomes are better with or without retreatment of rebound, which is an interesting study. Haven't seen that. I do it for people who are, again, high risk, super immunocompromised or whatnot, because the margin is narrower. But I think most of the time you're going to be fine, except you may not feel so good.
Perfect. Thank you. Dr. Saberman has a great question. So curious about the role of home rapid flu and or RSV testing. Home COVID testing is just now a given. Why aren't we there with flu yet?
Yeah, so there are 2 approved multiplex home tests, FDA approved or authorized, EUA rather, that test for flu and COVID or flu COVID RSV. They're antigen based. So pros and cons, right? Antigen tests are very specific, but not as sensitive as PCR. They're also expensive. I do think that's like the way of the future, but the problem is societal community interest in this, plus funding and subsidies are both waning to some degree. So there probably was a maybe earlier window for that to be taken up more. But if we all had that in our houses and stuff, or daycares or whatever, that would be nice.
Perfect. And Dr. Counts asked, how long do you recommend waiting on COVID boosters after getting COVID? 2 to 3 months, or sooner, or later?
Yeah, we did cover that. I think that's very reasonable. I think that's a very reasonable timeline. Also timing matters. Like if someone had COVID in May and it's, all right, let's rephrase it. It was they had COVID in March of last year, and we were back in like June. There wasn't a lot of COVID circulating. I would say probably like lag it until you see more COVID in the community, which we were hoping would be just seasonal, but we had that kind of late August kind of surge. So I think I also tell people, hey, 1 to 2 weeks or so, 2 weeks ideally before you have some planned risk event is a reasonable time to think about getting vaccinated, whether that's Thanksgiving, international conference, or travel. You tend to, between weeks 2 and 12, have probably your greatest neutralizing antibody circulating and lower risk of getting infected.
Thank you. And Dr. West, it says, how long out from a stem cell transplant could one expect to have improvement in viral fighting ability?
Oh yeah, well, so that's very individualized, unfortunately, depending if you have complications, graft versus host disease, the intensity of your transplant. Usually by 2 years post-transplant, if you're off medicines and you don't have graft versus host disease, you're looking pretty good for most people. It depends, though. The 6 months to 2 years really depends on kind of the intensity of the stem cell transplant, and underlying malignancy, things like that. How long you were on GVH prophylaxis. So then it's a little bit sketchy.
Awesome. And I know there's a couple questions on long COVID. I know we talked about metformin already. Dr. Whipple, thank you for addressing that during your slides. Is there any support for low dose naltrexone for long COVID? Dr. Londano's asking.
Yeah, I don't think there's any of that outside of, there might be clinical trials ongoing for that. That's a relatively benign medicine. I haven't prescribed that. I would probably not recommend it, but there are a couple of, the problem I think is that there are many problems, long COVID problems, but one of the ones are probably that people cluster differently in terms of pathogenesis and things that are awry. So it's a little bit hard to have a, one brush to treat all of them. I think data-wise, there seem to be issues with the cortisone axis in some people. That's something that could be addressed in one way. Maybe there are actually problems in the serotonin axis, could be addressed one way. People who manifest as like POTS are different than people who manifest as shortness of breath. So it's a bit hard. And I think tragically, we're just not at a great place to have great guideline-based care recommendations. I would just probably try to do no harm in the data vacuum.
Got it. And I think along those same lines, there was some of our colleagues said that some patients were asking for Diamox, some maybe asking for fluvoxamine for long COVID.
Yeah,
Any on those?
I don't think we have any strong evidence for that. Again, I just do no harm with whatever we're planning, and you really would want to have people honestly ideally seen in like a multidisciplinary PATS clinic or long COVID clinic, and they can be a little bit phenotyped and help with that. Physical medicine rehab doctors have been a pretty good resource for that, which they're pretty worldly, I'd say.
Perfect. And then to wrap up our COVID questions, Dr. Counts asked, can you comment on the current thought on risks of steroid use for asthma flare, for example, and COVID as it differs from use with symptoms from flu or other viruses?
Yeah, that's a good question. There is relatively strong recommendation to not use steroids primarily for treatment of COVID in outpatients and people who are otherwise stable amount of oxygen. For people who have a concomitant inflammatory lung disease, for whom you would otherwise in a vacuum give steroids, there's equipoise, but at this stage, particularly in people who are, it's sort of an axis of their COVID risk and their asthma severity. I mean, people who are like, I've been in the ICU twice for asthma, like you should probably just give them steroids. People who have very mild intermittent asthma who you're kind of on the fence about giving steroids, maybe a reason to not be leaning that way because it does impair virus sort of clearance. And people who are in the early viral phase of COVID, this is the reason why we tend to not give it. I would be a little surprised if 5 days or whatever it is of a steroid burst or something for a person who's otherwise stable is going to tip them into some horrible disseminated viral situation. But I would probably more look through the lens of the asthma severity as the driver of your decision to give steroids.
All right, perfect. So moving on to our RSV and flu questions, Dr. Counts asked, do you anticipate that RSV vaccines will be ever lowered to age 50 or for high risk patients or not?
Yeah, it's a really good question. I don't know. I don't think it will be for people unless they have an immunocompromising condition, would be my bet. Because they're going to be, we'll see what the real world effectiveness data show. There's already discussion about whether children, should be, that's not approved for children right now. They should be doing that. So I think that'll be probably first, and then immunocompromised people, and then everyone else. That I would bet it doesn't go there because there's so much vaccine kind of like fatigue and whatnot. And you got to pick your spots.
Speaking of vaccine fatigue, Dr. Treadwell asked, do you recommend a second flu shot if people get it very early, especially if they are very high risk?
That's a good question. There are data for that. There have been clinical trials in lung transplant recipients, for example, that show that it does help. Because again, you tend to have waning immunity after 3-4 months. And if you got it September 1st, and then you're a lung transplant recipient, which is a very high risk person, people do give a second dose. And but for the average individual, not usually done. For the kind of in-betweens of like, again, you're 80, you don't have lymphoma, but you're not that healthy, and you live in a nursing facility, and that's like a reasonable niche. You can sometimes run into insurance issues though. So, if you got the first one in a van on a drive, and then you want to use your insurance bullet, so to speak, for your second dose in January for grandma in, facility, like honestly, that hasn't really been studied to my knowledge, but it's not it's a reasonable thing. It's obviously a very safe intervention.
Absolutely. And then Dr. Saberman asked, do you have any thoughts on the Novavax vaccine timing if a patient's up to date on their mRNA COVID boosters?
Yeah, I'll say just full disclosure, I do get consulting fees from some of the companies I mentioned, including Novavax. But we don't have as much information as we should on Novavax, to be honest. I mean, it's just not been around. Very few people have taken it. So I can't tell you one way or another whether it's going to be better or worse than if you had serial mRNA vaccines. There've been a couple of trials, but a while back. For now, the CDC treats them all kind of the same, so I would treat them all kind of the same. Like if you're due for one and you want the other one, that's fine. There are some theoretical benefits to switching vaccine platforms in general due to kind of, let's say, quality of antibody or epitopes against which people develop antibodies that could maybe be broadened. That's hypothetical. Or people who have documented poor response to mRNA vaccines because of immunosuppression, using an adjuvanted vaccine may be beneficial. But other than that, it is still kind of hand wavy.
All right, perfect. And then I know that we talked about like at-home flu tests, but any news on maybe getting any like at-home or over-the-counter RSV tests, if that's a thing that's on the horizon, potentially?
Yeah, I mean, and I forgot the names of the two. I have to look at Google them. The problem is that our RSV therapies are so poor that, like, what are we going to do with that information apart from showing the presence of something that's not COVID or flu? You know, you can help a little bit with prognostication for little kids, but they should probably be seen in a medically attended kind of, setting if you're going to be worried that way about it. So that's probably not going to be a big growth area.
Perfect. And I think Dr. Chandler asked about low-dose naltrexone. I think we answered. There's enough evidence on that. But we'll have a recording available for everybody, and we'll have Dr. Wirbel's slides as well that we'll post on the physician thread. I think those are all the questions we have. Dr. Wirbel, do you have any other comments or any closing comments for us?
No, and I'm just sorry that we had a little bit of a rocky start. I mean, I'm available to chat. If kind of there's some specific questions in a non-HIPAA, clinical guidance kind of way, but I think this is super exciting and very interesting kind of time. And, if we're educated about it, we can probably take advantage of a lot of the things to keep people safe and healthy this winter. So hope this was somewhat useful.
All right. Well, thank you so much, Dr. Wirbel. We enjoyed having you. Welcome back to PlushCare, and thank you again for taking the time to talk to us about all these amazing viruses. And thank you so much again.
No, it was great to see some of your faces, and like I said, let me know. Yeah, hopefully my email will go around, and you're welcome to reach out.
All right. Well, that's it, everyone. Thank you.